Good evening, everyone. I'm Professor Paul Sidhu from King's College Hospital in London, and welcome to this BRACO-supported symposium that we're putting on for you tonight with 3 speakers. The symposium is entitled Advantages of Contrast Enhanced Ultrasound in the Management of Patients with Known or Suspected Liver Disease, and we have chosen 3 topics that will be relevant to everyone who's joining the meeting today. Besides myself, we have 2 other speakers. We have Professor Eddie Lean, who's a consultant radiologist at the Princess Grace Hospital, who will be talking to us about contrast-enhanced guidance and peri-procedural assessment of ablation therapy. And we have Pamela Parker, who's a consultant sonographer at Hull University Teaching Hospitals, who's going to look at liver contrast-enhanced ultrasound and the importance of the collaboration between the radiologist and the sonographer. We're going to go through each of the talks tonight, and then we'll have open it up to questions at the end. But also, you are able to use the chat line during the course of all the lectures, and do send in questions because we will answer them online as we're going through. I'm going to start and kick off the session looking at liver contrast enhanced ultrasound, why, when, and how, and in particular looking at the SonoVue NICE guidelines and the contrast enhanced EFSUMB guidelines, and show you how, why, and where you should be using it in clinical practice. I am Professor Paul Sidhu from King's College Hospital in London. I will talk to you about the application of liver contrast enhanced ultrasound, specifically why, when, and how, and talk to you about the SonoVue NICE guidelines and the liver EFSUMB guidelines during the course of this talk. First of all, the background of why, when, and how we should be using contrast and enhanced ultrasound in the investigation of liver disease. Let me take you back to 2007. This is a seminal paper produced by Brenner and Hall and published in the New England Journal of Medicine. This is nearly 15 years ago, but they anticipated that there was a problem with the amount of CT examinations that were being performed in the United States of America. The increase in the radiation burden over a period of 10 to 20 years from the introduction of CT to the year 2007, which also means that we are now at a level much higher in 2021, far exceeded expectations and also brought with it problems with the exposure to radiation. Radiation doses from various radiological studies are quite variable. Dental radiography, a chest x-ray, really quite small. But when you get down to looking at abdominal CT examinations, 10 millisieverts, and a neonatal abdominal CT, 20 millisieverts, you can see how the accumulative dose over many years could be detrimental to the patient. Not that CT in itself is a harmful imaging modality. Of course, it's very useful in getting to the diagnosis and helps a great deal of patients. However, it's important to remember that you should be using this with a view that these radiation can be causing problems. And this was pointed out in that paper by Brenner and Hall, which said, it estimated about 1.5 to 2.0% of all cancers in the United States may be attributable to radiation from CT studies. The estimated risks associated with CT are not hypothetical. They are not based on models or major extrapolations of dose. They are based directly on measured excess radiation-related cancer rates among adults and children who in the past were exposed to the same range of organ doses as delivered during CT studies. And this was further looked at with a large retrospective study of over 350,000 CT examinations in children, and they found that the radiation exposure from CT scans in childhood resulted in subsequent leukemia and brain tumors. Now, why do I tell you that CT is something that should be looked on with caution when you don't really need to do the study, but when there is an alternative available? Well, it's because we can use contrast enhanced ultrasound in these situations. Just moving on from that Brenner and Hall study, this was presented at the RSNA in 2018, looking at emergency use of CT and its exponential growth. And this takes in that period from 2006 to 2016, 10 years after the Brenner and Hall paper, and just look at the exponential growth in the number of CTs performed over this period of time. Of course, cardiac was in its infancy in 2006, so there is quite a rapid growth in the number of people undergoing cardiac CT, but this is also going to be reflected in the reduction in the number of angiographies performed, catheter angiographies for diagnostic cardiology. But look at the other areas, all of these increasing quite dramatically over this period of time. So as radiologists or anyone involved in imaging, you are actually duty bound to your patient to reduce the amount of radiation they are exposed to. And if you have another imaging modality which does not expose the patient to radiation, you should be using it. You should also remember that when you're doing a CT scan, an enhanced CT scan, you are also injecting contrast. Iodinated contrast is well known to have allergic reactions, and this should be taken into account when you are using contrast in any patient, whether a child or an adult. Now, what does contrast enhanced ultrasound and ultrasound have over everyone else? Well, it has a number of distinct advantages over CT and MR. You can perform it immediately without any preliminary laboratory testing, and this actually pertains to the fact that the contrast agents in ultrasound have no renal toxicity. In fact, they have no renal phase at all and are excreted via the liver and the lungs. So you don't need any preliminary laboratory testing for renal function. You can carry it out anywhere. You can take the machine to the patient. You don't have to bring the patient to the CT or the MR suite. And importantly, it operates in real time so that rapid changes can be captured. This again is important because when you look at patterns of enhancement, in particular in focal liver lesions and on CT, you're getting a snapshot in time produced for you by the technician taking the imaging in CT, whereas in contrast, you're observing it in real time and you can make your own opinion up on very subtle changes that come and go within a few seconds. And this is particularly true on the use of contrast enhanced ultrasound in looking at the vascularity in focal nodular hyperplasia, for instance. So what about the safety? We're talking about, first of all, that contrast enhanced ultrasound or even ultrasound could prevent a patient having an unnecessary CT, but we can also look and see whether or not the contrast agent that you're administering in with ultrasound contrast is in fact safer to the patient than the gadolinium or iodinated contrast. Remember, when you're injecting an ultrasound contrast agent, you're injecting 1, 2, 3, or 4 milliliters if you're using SonoVue. If you're injecting iodinated contrast agent, you're injecting 60, 70, 80, 100 milliliters of contrast agent. You inject less volume of gadolinium, but gadolinium has had its issues recently with retention of gadolinium in organs, and this is important also, of course, in children. So what about the evidence for safety in contrast enhanced ultrasound? Well, this is a retrospective study from the Italian Society of Ultrasound in Medicine and Biology, published in 2006, quite some time ago, but they looked at a large number of patients, in about 24,000 patients, and they found no fatal events. Adverse incidents occurred in 29 examinations, or 0.0086%. And these were mainly related to itching, nausea, warmth, dizziness, headache, and mild hypertension. They had only 4 adverse events which required treatment, 2 serious and 2 non-serious, and they came to the conclusion that there was a lower adverse event rate reported than contrast for CT and MR imaging. And this has held over the years with other examinations looking at the safety, and I draw your attention to this study of 30,000, which reported similar safety issues, and also this study in pediatric patients, which also showed a low incidence of adverse events. Post-marketing surveillance is a very important method of picking up any problems with a contrast agent, and this is safety data from 2.5 million patients over a period of time. Sorry, from 6,307 patients, and there's very little adverse events. And the fatality in the overall dosages emitted, that was 2.5 million, there were only 14 fatalities, and all of this was in cardiac, and all of these patients had severe cardiac disease. So 0.006% fatality in the post-surveillance assessment of contrast. What evidence do we have for contrast enhanced ultrasound that it actually works? Well, first of all, let's look at the radiologist reporting a CT scan. This is a patient with a cirrhotic liver, and perhaps on this unenhanced image, you see nothing in the liver at all. And this unenhanced CT examination is the equivalent of your unenhanced ultrasound examination that you look for abnormalities in the liver. No self-respecting radiologist would report an image without contrast, and of course additional contrast shows you these hyper-enhancing lesions consistent with hepatocellular carcinoma present in the liver. Look at the ultrasound here, the B-mode ultrasound, with what looks like an echogenic hemangioma. And after you administer contrast and you're imaging at the similar time that you're imaging in CT, and in this case, the equivalent would be the portal venous phase, and it disappears completely. This is a benign lesion and is a hemangioma. This is the B-mode ultrasound appearances of someone with metastatic liver disease, where you can see quite a few metastases, but the addition of contrast agents will allow you to see metastases down to 2 or 3 milliliters, not visualized clearly on the B-mode. So comparison of B-mode ultrasound with imaging in CT always compares the B-mode unenhanced image with a contrast enhanced CT examination. This is not a level playing field. What further evidence is there out there? Well, there's a lot in the literature on the different contrast agents that have been used in the past. The first agent, Levovis, which we used in the mid-1990s, is no longer available, but was the first agent on the market with a lot of research produced. SonoVue is the agent that you're very likely to use here in Europe, and there are other agents, Definity, Sonosoid, and Optison. And in total, you've got nearly 4,500 manuscripts in the literature showing you how you can use contrast and how safe it is and how diagnostically able it is for your liver assessments. And more importantly, recently, the FDA has approved the use of SonoVue, or Lumason as it's called in the USA, for use in liver investigations. This is very important because the United States took about 20 years to approve contrast agents in ultrasound, allowing Europe to be far ahead in the evaluation of this agent. The European Federation of Societies in Ultrasound in Medicine and Biology, for which all BMIS members are a part of, produced guidelines over the years. And this is the guidelines produced in 2004, very soon after the licensing of SonoVue in Europe, to update a guidance in 2008 and further update in other areas, but more importantly in the liver in 2012 and then 2020. So focal liver disease has evolved into the single most important application of contrast outside the heart. It shows marked improvement over conventional ultrasound, both in the detection and characterization of focal lesions, and equals contrast enhanced CT in many instances, and sometimes even exceeds the ability of contrast enhanced CT. Furthermore, pulling of data from various studies looking at the use of contrast enhanced ultrasound for focal liver lesions, and I'm referring to a paper by Richard Barr, and looking at how accurate it is, comparing various modalities against each other for both sensitivity and specificity. So how accurate? Here we're comparing unenhanced ultrasound to enhanced ultrasound. Well, the sensitivity of ultrasound alone in the study by Quare in 452 patients showed a sensitivity for picking up a focal liver lesion as low as 52 to 54% and a specificity between 40 and 43%. By adding contrast enhanced ultrasound to the B-mode ultrasound examination, the sensitivity came up to almost as high as 85%, and the specificity, and this is more important, up to 95%. And this was replicated in similar figures, but not quite so impressive in a study by Dye on 554 patients. So by adding contrast enhanced ultrasound to your B mode, you improve the specificity and sensitivity dramatically. Now, what about directly comparing contrast enhanced ultrasound to contrast enhanced CT? Several studies have looked at this, and all of them demonstrate an increase in sensitivity and specificity. And I'm looking here at the DEGEM, which is the German Ultrasound Society study reported by Karl-Heinz Seitz, and looking at 267 patients in a multi-center study. The sensitivity of contrast-enhanced ultrasound was 95.3% in this study, and the sensitivity of contrast-enhanced CT was 90.6%. So in fact, contrast-enhanced ultrasound outperformed CT. And similar figures for the specificity, 83 and 81%. And this was reported in 2009. And the technology associated with the use of contrast-enhanced ultrasound has, of course, improved dramatically over the last 10 or 12 years. So these figures will hold true, if not improve even further. How good is it at characterizing lesions? So again, this is pooled data from the paper by Barr, looking at hemangiomas, focal nodular hyperplasias, hepatocellular carcinoma, metastases. And you can see the sensitivities are very high, but particularly the sensitivity for picking up metastases is 91%. So the conclusion in this paper, based on all the literature, was that the widespread use of contrast-enhanced ultrasound is appropriate for focal liver lesions. And this, remember, is a United States-based paper. Standard of care needs to change to include contrast-enhanced ultrasound for characterization of focal liver lesions. They have achieved this in the United States, not only for getting licensing for the contrast agent for evaluation of focal liver lesions, but as is important in the United States, they are also now being reimbursed for the assessment of focal liver lesions using contrast-enhanced ultrasound. So from this, we've seen that it's accurate and can exceed contrast-enhanced CT. This is the DEGEM paper that I referred to, which demonstrated the accuracy of using contrast-enhanced ultrasound, and in particular, it was extremely reliable for differentiation of benign and malignant lesions. And this is your main job in your ultrasound room, is to tease out those lesions that need further investigation, which are malignant, from those of benign. And it was particularly good for diagnosing hemangiomas of FNHs. But is it cost effective? Well, a second German paper in the German healthcare system showed that it was a much better investigation for downstream cost savings in the German healthcare. So you've got a technique that is accurate, sensitive, specific, and is also cost effective. So what about recommendations in the United Kingdom? Well, NICE recommendations are what we all look to. NICE, the National Institute for Health and Clinical Excellence, is a government-based body which looks at particular problems or conundrums within the medicine to see if they can resolve any issues arising from the use of a medicine or a technique, and make sure that this technique is cost-effective and beneficial to the National Health Service. So in 2012, NICE looked specifically at SonoVue as a contrast agent for contrast-enhanced ultrasound imaging of the liver. When NICE looks at something, it's very comprehensive. There's a large team, there are panels and meetings to decide what should and shouldn't be included. The literature is well researched, and they come up with a final conclusion. So they were looking at focal liver lesions and the distinction between benign and malignant lesions to see if contrast-enhanced ultrasound would help. They determined that up to 75% of focal liver lesions assessed in the UK do not need treatment. So this means that when you see an incidental lesion on ultrasound, you are subjecting 3/4 of your patients to unnecessary further investigations, which could potentially have a cost saving for the national health system. And they estimated from their referencing and their research that sensitivity of contrast enhanced ultrasound was 95%, CT was 94%, specificity 93 and 93. So they too found that the sensitivity, specificity, and with it accuracy was quite high. So what were the recommendations for NICE for the use of contrast enhanced ultrasound? And really, NICE, if they make a recommendation, we are more or less obliged to follow this in the NHS. So they've recommended several things that if you're working in the NHS and you're working in ultrasound, this is what you should do. When you see a focal liver lesion, SonoVue is recommended for characterizing incidentally detected focal liver lesions in adults in whom an unenhanced ultrasound is inconclusive. And this is the key word, inconclusive. An unenhanced ultrasound scan in which a focal liver lesion is detected but not characterized is defined as inconclusive. Contrast enhanced ultrasound is recommended for investigating potential liver metastases in adults. If you've got a screening program where you're using ultrasound to detect liver abnormalities in patients with known underlying treated bowel or breast or lung cancer, if you see multiple metastases on the B mode, you can stop there because it's not an inconclusive scan. But if you don't see metastases, are you really doing a service to the patient? And this is where perhaps contrast should be introduced. If contrast enhanced CT is equivocal or unenhanced ultrasound is unsatisfactory in the diagnosis, then you've got to use contrast enhanced ultrasound again. And also you should be using it for characterizing focal liver lesions in adults where cirrhosis is being monitored. And this is probably, all these areas are probably where most of the United Kingdom hospitals are not observant to the NICE guidelines. So in this flow chart, when you're doing a conventional ultrasound and you've performed it, you see a focal lesion and you're absolutely know it's benign, then you don't need to do anything further. If you're uncertain, then you should be using contrast enhanced ultrasound. If it's inconclusive, you should be using contrast enhanced ultrasound. But if you can see it's clearly malignant, you may not need to use contrast enhanced ultrasound, but should go on to staging and referral of the patient. So adding contrast enhanced ultrasound at this point in time will allow you to differentiate the benign and malignant lesions and therefore assign the patient to a different pathway. And this is important in your ultrasound examination because most of your patients will be general practice referrals, outpatient referrals, and we're not talking about referrals from the oncology clinic where an underlying carcinoma or cancer is known. Remember, the patient is watching you scanning, and when you see a focal liver lesion, they do know that you've seen something abnormal. And isn't it best to be able to reassure the patient that it's benign at the time? So an incidental focal liver lesion is now found at ultrasound. How often or what proportion of focal liver lesions detected by unenhanced ultrasound are inconclusive? And this is a paper from Newcastle published in the Ultrasound Journal, which is the journal of the British Medical Ultrasound Society, from Tim Hoare's group. They looked through many, many records of referrals from general practitioners. And of all the referrals from general practitioners, focal liver lesions were seen in 746 patients, of which 18.4% were inconclusive. From outpatients, 12,500 patients, 1,437 focal liver lesions seen, of which nearly 30% were inconclusive. So the incidence of indeterminate focal liver lesions is considerable, both in the GP and the outpatient setting. So you're going to see quite a number of indeterminate focal liver lesions. And the current practice with most people is to, if you think it's benign, you may follow it up in 3 months. If you think it's malignant, you send the patient through to a cancer pathway and with all the downstream costs involved. But importantly, as I've mentioned before, it's the patient here that's more important. You've done the scan, you think it's malignant, you refer it back to the GP refers the patient to a clinic, 2-week pathway, the patient is seen, further investigations are ordered, 60, 70, 80 days later, the patient gets the result, and it's benign. So anxiety has been there for 2 or 3 months. We've touched on whether or not how many lesions are benign or malignant with the NICE guidelines, but these are two further studies produced in 2010 and 2011, both looking at incidental lesions, then assessed with contrast enhanced ultrasound, and up to 96% of these lesions were benign. So most of the patients that you see with incidental liver lesions are going to have a benign lesion, and this will be higher in the referrals from the general practitioner. So now let's have a look at a few cases that we've examined as incidental liver lesions. This is a 38-year-old female patient from the general practitioner, abnormal liver function test, and they think she's a fatty liver. Yes, she does have a fatty liver. That's quite clear from this view, but this is seen in the epigastrium. It's a mass. Now, if you see something like this, which is fairly atypical in a patient of 38, you may say, well, it's something to be worried about, but she's young. But let's just start by doing that contrast enhanced ultrasound. And if we look through that video as it's been played, and I'll play it again in a second, you will see that there is, at the very beginning, an area of focal spoken wheel vascularization, and then a scar at the end. And this correlates with the imaging that she had performed later, because of course you can never convince your physicians not to do something more when they have the opportunity. And the MRI confirmed that this is a focal nodular hyperplasia. But at the time of the examination, when contrast was employed at the same time, it was clear that this patient had a focal nodular hyperplasia, and there was no need to rush through and to put this patient on a pathway for MR or CT. This is another patient, a 45-year-old female with upper abdominal pain. Are there gallstones? Again, you would agree with me, this is an atypical lesion, but adding contrast to that patient, and it only takes 3 or 4 minutes to added to the examination to do this, you can see there's gradual infilling, and rather eccentrically in this patient, but with globular enhancement around the periphery. This is pathognomonic of a hemangioma. Again, you've knocked it on the head. Immediately, the patient doesn't need to come back for anything further. You've diagnosed a hemangioma. Another lesion, a little bit atypical, on the edge of the liver in an 85-year-old man with upper abdominal pain. But again, the lesion fills in from the outside, and you can see it fills in completely over time, and this is a hemangioma. These are two different patients, and again, though I've said the vast majority of your patients will have benign lesions, this is a 49-year-old patient, this is a 69-year-old patient. Both have underlying breast cancer and a focal liver lesion. This particular lesion looks atypical. It's a fatty liver and it's low reflective, but it's clearly on contrast enhanced ultrasound, a hemangioma. It stays bright at the end of 3-4 minutes after the administration of contrast and doesn't wash out. This patient has got a metastasis. It's low reflective in a fatty liver, but there is washout in that lesion. And you can ascertain the difference between these two lesions rapidly in your ultrasound clinic and triage these patients appropriately. This patient can be discharged back to the general practitioner care or the care of the oncologist with a benign diagnosis. This patient needs further follow-up by the oncologist and further treatment, and perhaps a staging CT. However, you may use this opportunity at this time to ascertain whether there are other metastases with the liver by doing sweeps through the liver in the late phase, looking for these punched out black holes to signify the presence of multiple metastases. A single metastasis in this instance may be amenable to local therapy. Let's move on to the European Federation of Societies in Ultrasound and Medicine and Biology, EFSUMB, and the guidelines they have produced. EFSUMB is a society of about 20,000 members made up of all the national societies throughout Europe, consisting of about 32 members. If you're a member of the British Medical Ultrasound Society, you're automatically a member of EFSUMB. And EFSUMB collects together much expertise across Europe, And Europe has considerable expertise in contrast enhanced ultrasound, as they've been performing this for about 25 years. So as I mentioned earlier, the first guidelines were produced in 2004 with an update in 2008, and we're talking mainly about liver contrast, but other guidelines have been coming through. In 2011, non-hepatic applications were talked about, and this is a controversial subject because, of course, SonoVue is not licensed outside the liver except for the breast, peripheral vascular system, and heart. But here are European experts contributing to the use of contrast in a non-licensed position. 2012 saw the third in line of the liver contrast enhanced ultrasound documents, further documents on update on the non-hepatic in 2017. A position paper on pediatric practice was also issued, but this is what the latest guidelines produced are, and published both in European Journal of Ultrasound and the Ultrasound in Medicine and Biology, which is the parent publication of all the world's societies in ultrasound. The importance of these guidelines should not be underestimated. They're seen as the benchmark for all contrast-enhanced ultrasound examinations of the liver. Suffice to say, the contrast-enhanced ultrasound is available quite in a large number of countries worldwide, though there are some particular areas where it's not yet licensed or used in any great detail. But this reflects also the infrastructure of the medical practice in these countries and the ability to support the use of contrast by the companies that are commercially responsible for these agents. In the most recent contrast enhanced ultrasound guide for liver lesions, it's a large document. It's over 20,000 words, 281 references, and 38 authors contributed to this document. And it's quite a task to write guidelines. Each of the authors are tasked with a particular aspect to do the literature search, read the literature, and ensure that the evidence that is produced for making any recommendations is robust. It is discussed and debated by all the authors together before the final document is produced. So it takes about 3 years to produce a set of guidelines. And in the most recent guidelines, there are 38 recommendations for the use of contrast-enhanced ultrasound, from safety right through to the ability to recognize artifacts associated with contrast-enhanced ultrasound. And within the document, and the document is all you need to actually perform a contrast-enhanced examination or set up a service looking at focal liver lesions, the actual patterns of enhancement through the arterial phase, the portal venous phase, and the late phase have been worked out over the years, such that benign lesions like hemangiomas, focal nodular hyperplasias are very easy to differentiate, but the cardinal feature of a benign lesion is the retention of contrast in the late phase. The post-vascular phase is something that can occur up to 10 minutes after the injection of contrast, but only with specific contrast agents. And the post-vascular phase refers in this particular instance to Levavis, which is no longer available, but more importantly now to Sonosoid, which has this post-vascular phase. Hepatocellular adenomas have its own nuances in that it doesn't always remain bright at the end, and sometimes some slight hyper-enhancing is noted. And the differences between focal fatty infiltration and sparing, abscess formation, and simple cyst all have characteristic features. The malignant tumors are different, and this is all based on the patterns of enhancement in the non-cirrhotic liver. So metastases, the hallmark of metastases is that rapid hyper-enhancing appearances, which sometimes occur a few 30 to 40 seconds after the injection. HCC will show some examples in a moment, and cholangiocarcinoma also have typical features seen on contrast-enhanced ultrasound. So the actual clinical diagnosis and practice of contrast-enhanced ultrasound on focal liver lesions is so well established now that it's not a difficult diagnosis to make with experience gained over the years. when looking at contrast enhanced ultrasound for LIRADS or looking for HCC hepatocellular carcinoma in the liver, and these are the liver classification produced by the American College of Radiologists to match the LIRADS for MR or CT. And this working group put together the findings to make recommendations. But the recommendation from the EFSUMB guidelines that it can be used as a first line to characterize focal liver lesions in liver cirrhosis to diagnose malignancy or HCC, but CT and MR remain required for accurate staging of these patients. So you are using it as a surveillance tool rather than as a staging tool. And this is the classification. It goes from LR1 right through to LR5. And LR1 and 2 are benign lesions. It's when you get into LR3, 4, and 5, remember in the cirrhotic liver we're talking about, the chances of malignancy increase as you go up to LR5. So you're looking really for that washout in that patient in the LR5. It also takes into account that you can't actually see or examine that lesion. You can't on the ultrasound make a diagnosis at all. It takes into account tumor in the vein as well as an added issue. And LRM is where it's clearly a metastases. The requirements for imaging for HCC in a cirrhotic liver with contrast are slightly different because you have to go on for at least 5 to 6 minutes, because if it's a well-differentiated hepatocellular carcinoma, it takes that much longer to wash out. But it's the arrival of those microbubbles and the intensity of the arterial phase enhancement that is probably a little bit more important than seeing just the washout, though the washout remains crucial. So these are the tables that are produced by the LIRADS group looking at patients with indeterminate nodules in the cirrhotic liver, and they've divided into arterial phase hyperenhancement, no arterial phase in hyperenhancement at the very beginning, to the presence of arterial phase hyperenhancement. And this is not rim enhancement, not peripheral discontinuous globular enhancement, which are very specific to diagnosis. And they're divided into the size of the lesion. So if you haven't got peripheral enhancement and your lesion is greater than 20, with mild washout, you have a very strong chance of having a HCC in a cirrhotic liver. But if you're hyperenhancing, that lesion can be smaller. And if there is later mild washout, it is characteristic of an HCC. So just in conclusion, liver contrast enhanced ultrasound, why, when, and how? Well, why? Contrast enhanced ultrasound is a dynamic, accurate investigation with an immediate answer. It negates the need for more expensive downstream imaging. It's patient-friendly and safe in adults and children, bearing in mind most of the incidental lesions that you see in your practice are going to be benign. You serve the patient better by doing an immediate contrast-enhanced ultrasound examination. When? Well, immediately following the indeterminate focal liver lesion is the ideal position to be in. This is not going to be readily available in all imaging departments, but it's a goal that should be sought. If your CT or MR image is actually indeterminate, you can use contrast enhanced ultrasound as a problem-solving tool. And this is because you're seeing it in real time. You pick up the vascularity in the arterial phase that may be very transient, that CT will miss. And how? Well, follow the EFSUMB and NICE guidelines, and you can't go wrong. Thank you very much.